Welcome to the deep dive. Today we're tackling a topic that's, well, really common, but often quite personal: alopecia, hair loss.
We've got some pretty detailed notes here, the kind you'd want if you were revising maybe for something like the MSRA.
Exactly. Think of us as helping you sift through these notes. We're not just going to read them out. The idea is to, pull the key stuff, connect the dots on alopecia, especially androgenetic alopecia, which seems to be a big focus here.
Right. We'll walk through what the notes cover, the definition, what causes it, the risk factors, how it actually works biologically, what else it might be mistaken for the differentials, how common it is, what it looks like, investigations, management, prognosis, and importantly, the complications.
Yeah, turning those dense notes into something a bit more memorable, a bit more conversational.
Okay, let's unpack this. So starting right at the beginning, what is alopecia according to these notes?
Well, simply put, it's partial or complete hair loss. Scalp, other body parts, anywhere really. But straight away, the notes make a really important distinction: scarring versus non-scarring alopecia. And why is that split so crucial?
Because scarring alopecia means the actual hair follicle is gone, destroyed, replaced by scar tissue. So that patch of hair loss, it's likely permanent.
Wow, okay.
Whereas with non-scarring, the follicle's still there, just
Yeah.
not working right. So there's at least the potential for hair to grow back.
Got it. Scarring factory burned down. Non-scarring factory maybe just closed temporarily.
Hmm.
Makes sense why that's point number one. The notes also dive into the normal hair cycle, which seems fundamental.
Oh, absolutely essential.
Yeah.
You need to know what's normal to spot the abnormal. The follicle isn't static. It cycles through phases. The notes list three: Anagen, that's active growth; Catagen, a short transition; and Telogen, the resting phase.
And the timings are pretty specific here. Anagen, the growth bit, is long notes say 3 to 5 years. Catagen is super short, like 2 weeks. Telogen resting about 3 months.
Right. Good numbers to fix in your head for revision. Anagen is longest, 3 to 5 years. Catagen, blink and you miss it, 2 weeks. Telogen, a few months rest, 3 months. Then at the end of Telogen, the new anagen hair starts pushing the old one out.
Which explains why we shed hair normally every day. The notes mention, what, 50 to 100 hairs a day is normal?
Exactly, that's the benchmark. So if you're consistently seeing way more than that, you know, big clumps,
Yeah.
it suggests something's disrupted the cycle, maybe push too many hairs into that shedding telogen phase at once. Keep 5100 in mind.
Okay. And this normal shedding leads us nicely into androgenetic alopecia, male and female pattern baldness, which gets a lot of attention in these notes. The patterns are different, right?
Yeah, quite distinct. For male pattern, the notes describe that classic bitemporal recession, thinning at the temples, maybe combined with thinning on the crown, eventually leaving that sort of horseshoe pattern.
And female pattern.
More diffuse thinning, usually over the top of the scalp. The front hairline often stays put, but the parting might look wider, more scalp visible overall.
Interesting how specific those patterns are.
It is. And it points towards the underlying cause. We'll get to certain follicles in certain areas being sensitive to hormones. It's not random.
Okay, so that's the what. Let's move to the why. Etiology. The notes list a whole bunch of potential causes.
They do. Broad categories first. Things like autoimmune issues, hormonal imbalances, genetics, a big one, certain medications, stress, nutrition problems, even physical trauma. Shows how many roads can lead to hair loss.
And these causes lead to specific types of alopecia listed: androgenetic, the pattern stuff; alopecia areata, often autoimmune; telogen effluvium, stress-related shedding; anagen effluvium, like from chemo; and trichotillomania, hair pulling.
hmm Plus, the notes highlight hair loss as a sign of other things going on. Skin conditions like seborrheic dermatitis, lichen planus, fungal infections like tinea cupitis, bacterial like impetigo, or systemic issues, secondary syphilis, thyroid disease, iron deficiency are all mentioned.
Wow, that's a lot to consider. Specific scalp conditions like psoriasis, too. And trauma gets a mention: traction alopecia.
Yeah, from tight hairstyles, weaves, that kind of thing, constant pulling. And scarring alopecia, cicatricial alopecia, can come from those inflammatory skin conditions: lupus, lichen planopilaris, infections, things that damage the follicle permanently.
There's that striking phrase in the notes about secondary syphilis causing glades in the wood hair loss.
It's memorable, isn't it? Like irregular moth-eaten clearings. For revision, that's high yield, a very specific pattern linked to a specific cause, useful for differential diagnosis.
Right. And speaking of who gets it, the notes list risk factors next. What makes someone more likely?
It ties back to the causes, really. Family history is a big one, especially for androgenetic alopecia, that genetic link. Having autoimmune diseases predisposes you. Other medical conditions like thyroid issues, age generally, risk increases with age, and gender plays a role. Males more prone to certain patterns, females more prone postmenopause for others.
Okay, so genetics and age are key for the common types, which brings us to pathophysiology. How does it actually happen on a biological level?
Well, the notes stress it's type dependent. Autoimmune is the immune system attacking follicles. Telogen effluvium is that sudden shift into the resting phase.
And for androgenetic alopecia, the notes go into more detail. Genetics and hormones were mentioned as risks.
Exactly. This is where we get follicular miniaturization, key concept. In people with a genetic predisposition, follicles in those pattern areas become sensitive to androgens, particularly DHT dihydrotestosterone. DHT makes these follicles shrink over time.
So they don't just stop working, they get smaller.
They get smaller, and instead of producing thick, normal terminal hair, they start producing thinner, shorter, less pigmented hairs. Vellus-like hairs.
Like baby hairs, almost.
Sort of, yeah. And the hair cycle itself gets messed up, too. The anagen growth phase gets shorter, telogen resting phase gets longer, so hairs shed more easily. It's this combination, miniaturization and a disrupted cycle, driven by that genetic sensitivity to normal hormone levels.
Okay, that makes sense. So we know what it is, causes, risks, how it works. But if someone presents with hair loss, it isn't always one of these types of alopecia, is it? What about the differential diagnosis?
Right, the what else could it be question. The notes list the main contenders to consider. Telogen effluvium, that's stress shedding, the androgenetic alopecia we've discussed, tinea capitis, fungal infection, trichotillomania, hair pulling, and cicatricial alopecia, the scarring types.
And you differentiate based on how it looks in the story.
Precisely. Telogen effluvium is usually sudden, diffuse shedding after a trigger, not patterned. Tinea capitis often looks scaly, maybe inflamed, broken hairs. Trichotillomania, irregular patches, hairs broken at different lengths. Cicatricial might show redness, scaling, and obvious scarring where the hair is gone. The presentation tells you a lot.
Helps narrow it down. Okay, epidemiology. How common are we talking, especially for that androgenetic type?
The UK figures in the notes are pretty stark for male androgenetic alopecia. Affects about half of men by the time they're 50.
Half. Wow. That's, yeah, very common. A key stat to remember.
It really is.
Yeah.
Female androgenetic alopecia is also common, particularly after menopause. The notes mention it's seen more in white Caucasian women over 70, less in women of Oriental origin, so there are ethnic variations too. Progression varies between people as well.
Okay, huge numbers affected then. Now, clinical features, what are the actual signs and symptoms?
It's a spectrum. Could be patchy loss, could be diffuse thinning all over, distinct bald patches, or even complete loss of hair on the scalp or body in severe forms. The notes really stress. The presentation depends heavily on the type and severity.
And we come back to that scarring versus non-scarring point again. Male pattern baldness is non-scarring, right? Scalp looks normal, just less hair.
Correct. But there's a crucial note about tinea capitis. Normally non-scarring, but if it gets really inflamed and forms a carrion, this boggy, painful swelling that can lead to scarring.
Ah, so carrion scarring risk in tinea. Good tip.
Definitely one to remember.
So if someone comes in, how do you figure out which type it is? Investigations.
Starts with the basics. A really good medical history onset, pattern, speed, stress, meds, family history, any other symptoms, and a thorough physical examination looking closely at the scalp, the hair itself, the pattern, any scaling, redness, broken hairs.
And if that's not enough?
Then you move to more specific tests listed here. Scalp biopsy, taking a tiny skin sample to look at under the microscope. Very useful for scarring types or difficult cases. Blood tests, checking for those underlying things like thyroid hormones, iron levels, autoimmune markers. And trichoscopy, using a dermatoscope, basically a magnifier with light, to get a really close-up view of the hair shafts and scalp.
Right, helps piece together the puzzle. Once you have a diagnosis, what about management?
It's tailored, of course.
Yeah.
But the notes give the main approaches. Medications topical or systemic. Lifestyle adjustments. Things like wigs or hair transplants are options too.
The notes also mention non-drug approaches. Like for some, acceptance is a valid strategy, especially maybe with male pattern baldness, and then aesthetic things, wigs, hairpieces, transplants.
Yes, and crucially, psychological support. Counseling, support groups, even just reassurance, helping manage fears about appearance. It's not just treating the scalp, it's supporting the whole person. That comes through strongly in the notes.
Definitely. And in terms of specific medications mentioned with evidence.
Two main ones highlighted. Minoxidil, that's usually topical, a lotion or a foam you put on the scalp. And finasteride, that's an oral pill. For revision purposes, those are the key names. Minoxidil, topical, finasteride, oral. The notes caution the evidence for other drug treatments can be limited.
Okay, good to know the main player. So after diagnosis and treatment, what's the likely outcome? Prognosis.
It really varies, depends hugely on the type of alopecia and how well someone responds to treatment, if any. Some types, like alopecia areata sometimes, or telogen effluvium once the trigger is gone, can have spontaneous regrowth. The hair just comes back by itself.
But not always.
No, permanent loss is possible, especially with scarring alopecia where the follicle is destroyed, or even in very advanced androgenetic alopecia. The specific diagnosis really guides the prognosis.
And finally, complications. Seems odd, maybe, but the notes list some important ones.
Hugely important, yeah. The main ones aren't physical, they're psychological.
Yeah.
Decreased self-esteem, body image issues.
The notes use the phrase significant emotional impact. That really stands out.
It does. And here's where it gets really interesting, I think. It's easy to dismiss hair loss as just cosmetic, but these notes underline the real emotional burden. It can affect identity, confidence, social interaction. It's a major factor in how people experience the condition.
Absolutely. It shifts the focus from just hair follicles to the person experiencing the loss. So that wraps up our walkthrough of these alopecia notes. We went from the definition, that key scarring, non-scarring split, through all the causes, the mechanisms like miniaturization, how to tell it apart from other things, who gets it, investigating it, the management options, including those key drugs, and the potential outcomes.
And crucially, landing on that significant emotional impact. Understanding these layers, from the biology to the psychology, as laid out here, should give you a really solid handle on alopecia, especially if you're revising.
It should. If you are using this for MSRA prep, remembering those details, hair cycle times, patterns like the horseshoe or glades in the wood, the carrion risk, minoxidil and finasteride, and that emotional weight, that's the high-yield stuff.
And maybe a final thought to leave you with. Thinking about how alopecia's main complication listed here is psychological distress really highlights the human side of medicine, doesn't it? How does remembering that emotional impact potentially change how you'd approach supporting someone going through this? Something to reflect on.
A really important point. Well, thank you for joining us on this deep dive into alopecia. If you happen to be revising for the MSRA, do check out passthemsra.com.
And for free resources that might help your studies, you could visit freesra.com.
We'll catch you on the next deep dive.